incident. Most of the time, those primary tumors, they are between 0 to 4 years old, then begin to rise in the adolescent. The second and fourth leading cause of cancer, related mortality in patient over 18 years and inferior to 34 years old. Secondary tumors, 25 all of the system cancer patient will have clinically apparent central nervous system disease, and 40 to 60% will have pathological evidence of central nervous metastasis. So the childhood tumors, 33% in anterior fossa, if you still remember the anatomy, anterior tumors, and 7% posterior fossa, like those astrocytoma, medulloblastoma, and primitive neuroectodermal tumors for 24%, ependymoma 14%. Metastatic are more common than primary brain tumors, but usually they are not biopsied. Of biopsy, 67% arise in the anterior fossa, like those glioma, 33%, meningioma, metastasis 2%, pituitary adenoma 5%. 33% is in the posterior fossa, like those schwannoma and the other miscellaneous tumors, representing 33%. So this is a general image on the location of the brain tumors, like those extracranial of meningioma. Here this meningioma, some gliomas on the cerebrum. Please unmute yourself. Well differentiated astrocytoma, anaplastic astrocytoma, glioblastoma multiforme, and oligodendroglioma. Those are found on the cerebrum. You see here those we call craniopharyngioma. And here pituitary adenoma. And this one acoustic schwannoma on the 8th nerve, cranial nerve. This one is very common, with the pontine glioma. Ependymoma on the 4th ventricle, medulloblastoma on the cerebellum, meningoblastoma, then astrocytoma in childhood. So this one in red, they are non-glio tumors, meaning that the glio tumors are astrocytoma and the gliomas, whereas those ependymoma, pituitary adenoma, craniopharyngioma, they are non-glio tumors. Please unmute yourself. A primary tumor, when the neuron is involved, is called gangliocytoma. The other is called ganglioglioma, and then medulloblastoma. They are astrocytes when they are well differentiated, and glioblastoma, oligodendroglioma, ependymoma, and the tumors derived from the microglia cells have not been described. Another one called meningioma are derived from the arachnoid cells, and usually euro-based. So in summary, these are the common tumors of the brain. According to the 2007 WHO classification of tumors of the central nervous system, there's tumors of neuroepithelial tissue, like those astrocytic, oligodendroglio, oligoastrocytic, ependymoma, choroid plexus tumors, other neuroepithelial cells like astroblastoma, neuron and mixed neuroglia tumors, tumors of the pineal region, embryonal tumors like medulloblastoma. Medulloblastoma is a common 5 small round blisters like that we have seen in the morning Ewing sarcoma. And neuroblastoma. Tumors of cranial and paraspinal nerves, those schwannoma, neurofibroma, Meningioma, and the malignant peripheral nerve sheath tumors we have seen in the morning. Tumors of the meningothelial cells, the parenchymal tumors, primary melanocytic lesion, they're also found in the brain, and other neoplasm related to the meninge, they are hemangioblastoma. As you see, even when you focus on the brain tumors, even brain tumors are many. Lymphoma and hematopoietic, they're also found there. Germ cells like germinoma, embryosarcoma, they're found in yolk sac tumor, choriocarcinoma, teratoma, and mixed germ cell tumors. Don't be surprised when they say choriocarcinoma in the brain. As someone who did the pathology, you will say it is possible there is yolk sac tumor, choriocarcinoma, and sarcoma. Whereas we have those yolk sac tumor in gynecology pathology. Tumors of cellular region, like those craniopharyngioma and metastatic tumors. So this is the comparison, primary versus metastasis, benign versus malignant, focal and diffuse, above or below tentorium, not common, some tumors not common in adult, and about 20% of childhood or malignancy are found in childhood. Location of the tumor is somehow critical because the location also depends on the prognosis. There are some rare cell type, rare of neuron origin, astrocytoma, microgliomatosis, and the pandemoma. So this means when you found a brain tumor, first of all, you have to grade tumor. If it is grade 1, grade 2, grade 3, grade 4. When it is grade 3 and grade 4, most of the time it is not it is malignant. For example, you can find a meningioma, then you say meningioma. When you give a diagnosis of meningioma, it is not enough. You have also to add grade. Is it meningioma grade 1, grade 2, grade 3, grade 4? Because meningioma grade 4, this one has a poor prognosis compared to meningioma grade 1. Grade 1 and 2 are benign, grade 3 and 4 are malignant. So keep in your mind, wherever you go and found a brain tumor, you have also to make sure that there is a grade of that tumor. For example, astrocytoma, they are astrocytic origin, above tentorium, most time in adult. Say have the multiple grade, 1, 2, 3, 4. They compress surrounding tissues. They have hemorrhage and necrosis. With higher grade malignant tumors, and then look for vascular growth. So this is an image of those astrocytoma macroscopically. This is during the surgical operation, and this one after the histology. Not only must you know those tumors, radiodiagnostic is very, very important in those tumors, because this one, apart from giving the diagnosis, but also the location, because you can't operate brain tumors without radiodiagnostic images, either CT scan or MRI. Astrocytoma, they could be glioblastoma multiforme. Glioblastoma multiforme. This is the heterogeneous group. And I have said before in general pathology, there's some molecular pathway to brain tumors like glioblastoma multiforme. There's some amplification of EGFA, epidermal growth factors, 10 mutation, RB alteration. This one is still under research. It is not used in diagnosis. Those platelet growth factors, P53, and others. So there's, once we found the glioblastoma in the research, we go for looking for mutation because this one also predicted the prognosis. This is a glioblastoma macroscopically, meaning that in a surgical operation you see in your surgery, you have to remove that tumor. Glioblastoma multiforme is grade 4 of astrocytoma, meaning that this one is malignant and it has a poor prognosis. It is the worst possible form of glioma. For this one, glioblastoma multiforme, even the survival rate it is less than 2 years with a proper treatment. Ependymoma, this one, remember the ependymal cells, the cuboidal cells. This one it is found on the ventricle. We have seen the location. Maybe once you be a neurosurgeon, service, once you report the sample from the brain, you have also to report to the pathologist the location of that tumor, because this one will help for the diagnosis. Otherwise, it can create a confusion. A medulloblastoma, this one is found in children in the midline, in the cerebellum, and the subarachnoid spread. These are radiological images. In this one, they are macroscopic images. Meningioma arises from meninge, benign in biological. So most of the time, meningioma, they are benign. But consider it can be fibroblast-looking cells in wheels and clusters. And they what we call some bodies. Some bodies are like a calcification, accumulation of the calcium tissue. So most of the time, meningioma, they are benign, but you have to grade. These are the some bodies. Those who calcify the material in the brain. So there are some pediatric tumors in neuropathology, development of abnormalities, neonatal disease, familial syndrome, perinatal lesion, and trauma. For this one, I don't go in those details. You will see them in your surgery, but most of the time they are related to folate deficiency, where they have the meningocele, which occur in lumbosacral region. This one you see them. I don't focus on this one today. There is some perinatal region of the central nervous system where there is some infection like torch. I've seen last time. Torch means Toxoplasmosis, rubella, cytomegalovirus, and herpes simplex, usually type 2. So this one, you see them again. I don't want to go in details because it will be too much for you. The peripheral nervous tumor, I've seen the neurofibromatosis, I've seen it in the morning. I don't want to repeat them, but what I want to tell you again,